Hello everyone, welcome to the kickoff meeting, a prospective study to compare uterine contractions from EMG and IUPC devices. My name is Priyadarshini Gnanashekhar and I am the project manager for this clinical trial. Let's get started. So the audience for this meeting will be Thomas C. Halsey, Frank A. Triber, Sachin K. Patel, Daniel Lackner, and Lydia King. So for this project we have a very unique hypothesis. So we are saying that EMG is a better approach in monitoring the uterine activity in contrast to IUPC. So we have a little bit of background over here. So the assessment of uterine activity is essential in the progress of labor during the time of delivery. So monitoring and acquiring uterine activity can be done by different methods, which includes tocodynamometry, intrauterine pressure catheter, and electromyography. However, it remains very unclear which is the best approach for monitoring the uterine activity during labor. So we are planning to do it as a prospective study, and the method will be women in labor will be monitored simultaneously with both the devices, the EMG and IUPC, for 20 minutes. And we would conclude saying that EMG is accurate in measuring the uterine contraction in contrast to IUPC by comparing time, frequency, intensity, and duration of contractions in both the methods. So what are uterine contractions? Uterine contraction is the consequence of electrical activity of the myometrial cells in the uterus. Oxytocin, estrogen, hormones control the mechanical and electrical activity of the myometrium. So when the pressure is more, the volume gets less mechanically. And endocrine, what happens in endocrine is estrogen, when there is more number of estro receptors, the membrane potential decreases, vice versa. So what are the different methods in capturing the uterine activity? So we have tocodynamometry, electrohistography, intrauterine pressure catheter, uterine EMG. So I have a picture of EMG to represent it, and also IUPC. So I've done a little literature review on this project. So previous study states that there is a high correlation between EMG and IUPC and a strong correlation of the times the contraction began. So once it has reached the peak and ended, P is less than 0.001. So that's the P value, and it is very supposed to be very significant. Correlation of contraction length was 0.94 with a P value of less than 0.001. So which says significance is really good. Study design and methods. So again, like I said, it's going to be a prospective study, and we have 5 pregnant women at the gestational age between 36 and 41 weeks admitted to the labor of the Medical University of South Carolina. They will be considered for the study. It is a single site study. We do not have any other multiple site, and will include only women for this study. So the materials that we are going to use are uterine EMG, which is non-invasive, with the surface electrodes aligned with expected direction of impulses, which will be in the women for like 30 minutes. At least one pair of electrodes must be placed on the maternal abdomen of a patient, matching the skin impedance of the patient to obtain the raw EMG signal. IUPC was used simultaneously to measure uterine contractions. So how do we process the data over here? So in order to eliminate the long and high frequency noise, the raw EMG signal will be processed by filtering and amplifying to a frequency band between 0.3 Hz to about 1 Hz to obtain an envelope of the signal that corresponds to IUPC signal. And what are the parameters we are looking for is time, frequency, duration, and intensity of each contraction. So how are we going to detect the contraction detection? So the contractions will be detected from EMG and IUPC using an algorithm which will be discard the maximum, which has an amplitude smaller than 5 mmHg or 0.01 MP. So contractions will also be rejected if the duration was less than 45 seconds and more than 180 seconds. The principle of this algorithm is that the maximum amplitude should be higher than 3/4 of the standard deviation of 7 consecutive maxima. In this way, a match could be identified between EMG and IUPAC contractions only if the peak of the EMG contraction was found with the duration of the IUPAC contraction. So statistical analysis will be performed using SAS program. Spearman correlation is the method that we are going to implement, and also Wilcoxon's signed rank test will also be used to compare the uterine contractile activity. So prior data indicates that there is a normal distribution difference in the matched pairs with a standard deviation of 13.1. So to be able to reject the null hypothesis, we will need 5 pairs of study subjects. Only if the true difference in their mean response is 27.3, this way we could reject the null hypothesis and the response would be 0 with a power of 0.95. So the eligibility criteria is patient should be, or the subject should be between the age group of 18 years to 40, and we accept only female patients, no healthy volunteers. Study population is pregnant women admitted to the Medical University of South Carolina with compliance of uterine contract starting. Women at term with complaint of uterine contraction. Women at gestational age between 36 and 41 weeks. Informed consent is required to be included in the study. So we do not need patients or subjects who refuse to sign the informed consent, and also subjects who are younger than 18 years of age. And we do respect and accept and agree to the ICH GCP guidelines. Participants will be ethically treated. They have the right to withdraw from the trial any time. Physicians will be informed in case of any discomfort to the patient. And these are the references for my project. Please let me know if you have any questions.